Hi, class. For our final lecture, we will be discussing matters related to neurocognitive disorders, selected disorders of childhood, ADHD, tic disorders, and finally, legal issues within the profession of clinical psychology. Let's get started. So, when we discuss neurocognitive disorders, we're going to discuss them to include, as always, their clinical presentation, epidemiology, etiology, and treatment options. Our discussion will include delirium, major neurocognitive disorder, and mild neurocognitive disorder. We also discuss 9 subtypes to include Alzheimer's disease, traumatic brain injury, vascular disorder, substance and medication induced dementia with Lewy bodies, frontotemporal NCD, neurocognitive disorder, Parkinson's disease, Huntington's disease, and HIV infection. Now, unlike many of the disorders we discussed thus far, neurocognitive disorders often result from diseases or disease processes or medical conditions. Therefore, it's important that individuals presenting with these symptoms complete a medical assessment to better determine the etiology behind their disorder. There are 3 main categories of neurocognitive disorders: delirium, major neurocognitive disorder, and mild neurocognitive disorder. Within major and minor neurocognitive disorder, there are several subtypes due to the etiology of the disorder. For our lectures, we will review diagnostic criteria for both major and minor neurocognitive disorders, followed by a brief description of the various disease subtypes in the etiology section. It's important to note as well that the criteria for various NCDs or neurocognitive disorders are based on defined cognitive domains. These include the following with a brief explanation of what it is. So, complex attention, which is sustained, divided, or selective attention and processing speed. Executive function, which is planning, decision making, overriding habits, mental flexibility, and responding to feedback or error correction. Learning and memory, which includes cued recall, immediate or long term memory, and implicit learning. Language, which includes expressive language and receptive language. And perceptual motor, which includes any abilities related to visual perception, perceptual motor praxis, or visual construction. And social cognition, which includes recognition of emotions and theory of mind. So delirium is first up, and delirium is categorized by a notable disturbance in attention along with reduced awareness of the environment. And the disturbance develops over a short period of time, representing a change from baseline attention and awareness, and fluctuates in severity during the day. There's also a disturbance in cognitive performance that is slightly altered from one's usual behavior. Disturbances in attention are often manifested as difficulty sustaining, shifting, or focusing attention. Additionally, an individual experiencing an episode of delirium will have disruption in cognition, including confusion of where they are, disorganized thinking, incoherent speech, and hallucinations and delusions may also be observed during periods. Delirium is associated with increased functional decline and risk of being placed in some sort of institution. That said, most people with delirium recover fully with or without treatment, especially if not elderly. But if undetected or underlying cause is untreated, it may progress to stupor, coma, seizures, or even death. Now, next is major neurocognitive disorder. And individuals with major neurocognitive disorder show a significant decline in both overall cognitive functioning, as well as the ability to independently meet the demands of daily living, such as paying bills, taking medication, or caring for oneself. Now, while it is not necessary, it is helpful to have documentation of the cognitive decline via neuropsychological testing within a controlled, standardized testing environment. Information from close family members or caregivers is also important in documenting the decline and impairment in areas of functioning. And within the umbrella of major neurocognitive disorder is dementia, which is a striking decline in cognition and self-help skills due to a neurocognitive disorder. The DSM-5 TR refrained from using this term in diagnostic categories as it's often used to describe the natural decline in degenerative dementias that affects older adults, whereas neurocognitive disorder is the preferred term used to describe conditions affecting younger individuals, such as impairment due to traumatic brain injuries or other medical conditions. Therefore, while dementia is accurate in describing those experiencing major neurocognitive disorder due to age, it's not reflective of those experiencing neurocognitive issues secondary to an injury or illness. We also have mild neurocognitive disorder, and individuals with mild neurocognitive disorder demonstrate a modest decline in one of the listed cognitive domains, and the ones that I listed previously. The decline in functioning is not as extensive as that seen in major neurocognitive disorder, and the individual does not experience difficulty independently engaging in daily activities. However, they may require assistance or extra time to complete these tasks, particularly if the cognitive decline continues to progress. It should be noted that the primary difference between major and mild neurocognitive disorder is the severity of the decline and independent functioning. Some argue that the two are earlier and later stages of the same disease process. Conversely, individuals can go from major to mild neurocognitive disorder following recovery from a stroke or a traumatic brain injury or TBI. The DSM-5 TR describes major and mild neurocognitive disorder as existing on a spectrum of cognitive and functional impairment. So, epidemiologically speaking, as individuals age, the rate of occurrence of delirium and dementia increases dramatically. Estimates for mild neurocognitive disorder among older individuals range from 2 to 10% at age 65 and 5 to 25% at age 85. As for Alzheimer's disease, prevalence rates are 11% of those age 65 and older and 32% of those older than 85. And men are more likely to experience a traumatic brain injury than women. Now, neurocognitive disorders occur due to a wide variety of medical conditions or injuries to the brain. Therefore, when we talk about this, we're going to focus on a brief description of the 9 different etiologies of neurocognitive disorders as per the DSM-5 TR. As you'll see, most of these neurocognitive disorders, per the DSM-5 TR, are both degenerative, meaning the symptoms and cognitive deficits become worse over time, as well as related to a medical condition or disease. So, in the DSM-5 TR, an individual will meet diagnostic criteria for either mild or major neurocognitive disorder. And in order to specify the types of neurocognitive disorder, additional diagnostic criteria specific to one of the following subtypes must be met. So first off, we have Alzheimer's disease. And this is the most prevalent neurodegenerative disorder. While the primary symptom of Alzheimer's is the gradual progression of impairment in cognition, it's also important to identify concrete evidence of cognitive decline. This can be done in one of two ways: via genetic testing of the individual or a documented family history of the disease, or through clear evidence of a cognitive decline over time by repeated standardized neuropsychological evaluations. Now, it is crucial to identify these markers in making the diagnosis of Alzheimer's disease, as some individuals present with memory impairment but eventually show reversal of symptoms. This is not the case for individuals with Alzheimer's. Now, autopsies of individuals diagnosed with Alzheimer's disease identify 2 abnormal brain structures: beta amyloid plaques and neurofibrillary tangles, both of which are responsible for neuron death, inflammation, and loss of cellular connections. It's believed that beta amyloid plaques, large bundles of plaque that develop between the neurons, appear before the development of dementia symptoms. And as these plaque bundles increase in size and number, cognitive symptoms and impaired daily functioning become evident to close family members. Neurofibrillary tangles are believed to appear after the onset of dementia symptoms and are found on the inside of cells, affecting the protein that helps transport nutrients in healthy cells. Both beta amyloid plaques and neurofibrillary tangles impact the health of the neurons within the hippocampus, the amygdala, and the cerebral cortex areas associated with memory and cognition. Now, researchers have identified additional genetic and environmental influences that in the development of Alzheimer's disease. Genetically, the apolipoprotein E or APOE gene that helps to eliminate beta amyloid byproducts from the brain has been implicated in the development of Alzheimer's disease. One of three variants of this gene, the E4LL, appears to reduce production of APOE, thus increasing the number of beta amyloid plaques within the brain. However, not all individuals with the E4LL develop Alzheimer's disease. Therefore, this explanation may better explain a vulnerability to Alzheimer's disease as opposed to the cause of the disease. Now, various regions have also been implicated in the development of Alzheimer's. More specifically, neurons shrinking or dying within the hypothalamus, thalamus, and the locus coeruleus have been linked to decline in cognition. And acetylcholine secreting neurons within the basal forebrain appear to shrink or die, contributing to Alzheimer's symptoms. Environmental toxins, such as high levels of zinc and lead, may also contribute to the development of Alzheimer's disease. More specifically, zinc has been linked to the clumping of beta amyloid proteins throughout the brain. And although lead has largely been phased out of environmental toxins due to the negative health consequences, current elderly individuals were exposed to these toxic levels of lead in gasoline and paint as young children. So there's some speculation that lead and other pollutants may impact cognitive functioning in older adults. And Alzheimer's disease is defined by the onset of symptoms. So early onset of the disease occurs before the age of 65. And while only a small percentage of individuals experience early onset of the disease, those that do experience early onset and early disease progression appear to have a more genetically influenced condition and a higher rate of family members with the disease. Late onset Alzheimer's occurs after the age of 65 and has less familial influence. This onset appears to occur due to a combination of biological, environmental, and lifestyle factors. Nearly 30% of individuals within this class of diagnosis have the APOE gene, I should say, that fails to eliminate the beta amyloid proteins from various brain structures. It's believed that the combination of the presence of this gene along with environmental toxins and lifestyle choices like more stress impact the development of Alzheimer's. Now, what about traumatic brain injury? Well, TBIs, as they're referred to for short, occur when an individual experiences significant trauma or damage to the head. Now, neurocognitive disorder due to a TBI is diagnosed when persistent cognitive impairment is observed immediately following the head injury, along with one or more of the following symptoms: a loss of consciousness, post-traumatic amnesia, disorientation and confusion, or neurological impairment. And the presentation of symptoms varies among individuals and depends largely on the location of the injury and the intensity of the trauma. Furthermore, the effects of a TBI can be temporary or permanent. Symptoms generally range from headaches, disorientation, confusion, irritability, fatigue, poor concentration, and emotional and behavioral changes. More severe injuries can result in more significant neurological symptoms such as seizures, paralysis, and visual disturbances. Major or mild neurocognitive disease due to a TBI may be comorbid with specified or unspecified depressive, anxiety, or personality disorders and PTSD. Rates of suicidal ideation are as high as 10%, with rates of suicide attempts hovering at around 0.8 to 1.7%. The most common type of TBI is a concussion. And a concussion occurs when there's a significant blow to the head followed by changes in brain functioning. It often causes immediate disorientation or loss of consciousness, along with headaches, dizziness, nausea, and sensitivity to light. And while the symptoms of a concussion are usually temporary, there can be more permanent damage due to repeated concussions, and particularly if they're close in time. Now, the media has brought considerable attention to this with recent discussions of chronic traumatic encephalopathy, which is a progressive degenerative condition due to repeated head trauma. And CTEs are most commonly seen in athletes like football players and military personnel. In addition to the neurological symptoms, psychological symptoms such as depression and poor impulse control have been observed in individuals with CTE. These individuals also appear to be at greater risk for the development of dementia. Now, neurocognitive disorders due to vascular disorders can occur from a one time event such as a stroke or ongoing subtle disruptions in blood flow with the brain, or within the brain, I should say. The occurrence of these vascular disorders generally begins with atherosclerosis or clogging of the arteries due to buildup of plaque. The plaque builds up over time, eventually causing the artery to narrow, thus reducing the amount of blood able to pass through to other parts of the body. When these arteries within the brain become entirely obstructed, a stroke occurs. And the lack of blood flowing during a stroke results in the death of neurons and loss of brain function. There are two types of strokes: a hemorrhagic stroke that occurs when a blood vessel bursts within the brain, and an ischemic stroke, which is when a blood clot blocks the flow in an artery within the brain. Now, while strokes can occur at any age, the majority of strokes occur after age 65. A wide range of cognitive, behavioral, and emotional changes occur following a stroke. Symptoms are generally dependent on the location of the stroke within the brain, as well as the extensiveness of the damage to those brain regions. For example, strokes that occur on the left side of the brain tend to cause problems with speech and language, as well as physical movement on the right side of the body, whereas strokes that occur on the right side of the brain tend to cause problems with impulsivity and impaired judgment, short-term memory loss, and physical movement on the left side of the body. After Alzheimer's disease, vascular disease is the second most common cause of neurocognitive disorders, and population prevalence estimates are 98% for those between the ages of 71 to, or 0.98%, I should say, for those between the ages of 71 and 79, and 4.09% for individuals aged 80 to 89, and 6.19% for those aged 90 years and up. Within 3 months of a stroke, 20 to 30% of people are diagnosed with dementia. Finally, stroke is more common in men up to age 65, and after that, it shifts to women. Vascular disease is frequently comorbid with a major or mild neurocognitive disorder due to Alzheimer's disease and depression. And there's also other forms of neurocognitive disorder, in particular ones that are due to substance or medication inducement. So significant cognitive changes occur due to repetitive drug and alcohol abuse. Delirium can be observed in individuals with extreme substance intoxication, withdrawal, or even multiple substances that have been used within a close period of time. While delirium symptoms are often transient during these states, mild neurocognitive impairment due to heavy substance use may remain until a significant period of abstinence is observed. There's also dementia with Lewy bodies, and symptoms associated with neurocognitive disorder due to Lewy bodies include significant fluctuations in attention and alertness, recurrent visual hallucinations, impaired mobility, and sleep disturbances such as rapid eye movement, sleep behavior disorder. While the trajectory of the illness develops more rapidly than Alzheimer's disease, the survival period is similar in that most individuals do not survive longer than 8 years post-diagnosis. Lewy bodies are irregular brain cells that result from a buildup of abnormal proteins in the nuclei of neurons. These brain cells deplete the cortex of acetylcholine, which causes the behavioral and cognitive symptoms observed in both dementia with Lewy bodies and Parkinson's disease. The motor symptoms seen in both of these disorders occur from the depletion of dopamine by the Lewy body nerve cells that accumulate in the brainstem. We also have major or mild frontotemporal neurocognitive disorder. And frontotemporal neurocognitive disorder causes, quote, progressive development of behavioral and personality change and or language impairment. And that's out of the DSM. So for the behavioral variants, individuals display at least three of the following: behavioral disinhibition, apathy or inertia, loss of sympathy or empathy, preservative or compulsive behavior, and dietary changes. For the language variant, they show prominent decline in language ability, like speech production, word finding, object naming, grammar, word comprehension. There is a relative sparing of learning and memory and perceptual motor functioning, but individuals with frontotemporal neurocognitive disorder commonly present in their 50s through the age of though the age of onset has a range of around 20 to 80 years. The median survival is 6 to 11 years after symptom onset and 3 to 4 years after diagnosis. There's also Parkinson's disease, and we've probably all heard of this. The awareness of Parkinson's disease has increased in recent years due in large part to Michael J. Fox's early diagnosis in 1991. It affects approximately 630,000 individuals. And while many are aware of the tremors of hands, arms, legs, face, and other of the main symptoms of Parkinson's disease, they include rigidity of limbs and trunk, slowness of initiating movement, and drooping posture, impaired balance, and coordination. These motor symptoms are generally present at least 1 year prior to the beginning of cognitive decline, although severity and progression of symptoms varies significantly from person to person. Onset of Parkinson's disease is generally from 50 to 89 years, and mild neurocognitive disorder develops early in the course of Parkinson's disease, while major neurocognitive disorder does not occur until individuals are much older. The prevalence of Parkinson's disease in the US increases with age and is more common in men than women. The disease is comorbid with Alzheimer's and cerebrovascular disease. Depression, psychosis, REM sleep disorder, apathy, and motor symptoms can make functional impairment worse. And then there's also Huntington's disease. And this is a rare genetic disorder that involves involuntary movement, progressive dementia, and emotional instability. Due to the degenerative nature of the disorder, there is a shortened life expectancy, and death typically occurs 15 to 20 years post the onset of symptoms. Although symptoms can present at any time, the average age of symptom onset is during middle adulthood, between the ages of 35 and 45. Symptoms generally begin with neurocognitive decline, particularly in executive function, along with changes in mood and personality. As symptoms progress, more physical symptoms present, such as facial grimaces, difficulty speaking, and repetitive movements. Because there's no cure for Huntington's disease, the severity of the cognitive and physical impairments ultimately leads to complete dependency and the need for full-time care. Suicide is unfortunately the leading cause of death of Huntington's disease, and it does have a course that leads to death for a number of different reasons, including a cessation of eating. There's now not many people are aware that cognitive impairment is sometimes the first symptom of untreated HIV as well. And while symptoms vary among individuals, slower mental processing, impaired executive function, problems with more demanding attentional tasks, and difficulty learning new information are among the most common early signs. When HIV begins or becomes active in the brain, significant alterations of mental processes occur, thus leading to a diagnosis of neurocognitive disorder due to HIV infection. Significant impairment can also occur due to HIV infection-related inflammation throughout the central nervous system. Fortunately, antiretroviral therapies used in treating HIV have been effective in reducing and preventing the onset of severe cognitive impairments. However, HIV-related brain changes still occur in nearly half of all patients on antiretroviral medication. There is hope that once antiretroviral therapies can cross the blood-brain barrier in the central nervous system, there will be significant improvement in the prevalence of HIV-related neurocognitive disorder. So, what are the treatment options? Well, treatment options for those with neurocognitive disorders are minimal at best, with most attempting to treat secondary symptoms as opposed to the neurocognitive disorder itself. Furthermore, the degenerative nature of these disorders also makes it difficult to treat, as many diseases will progress regardless of the treatment options. Pharmacological interventions for Alzheimer's disease target the neurotransmitter acetylcholine and glutamate, and newer research is focused on the buildup of beta amyloid and neurofibrillary tangles. Psychological treatments include cognitive and behavioral strategies such as playing board games, reading books, and social skills training. Caregivers need to join support groups to help them maintain and manage their own anger, depression, and pain, especially since 90% of such caregivers are relatives of the afflicted. So, for this last section of the course, we will be transitioning out of neurocognitive disorders and transitioning into disorders that are normally diagnosed in childhood. Now, it's important to note that this is not at all an exhaustive list, and instead is selected based on the fact that these disorders can indeed also be diagnosed later in life, within adulthood for some of them, and also because they are among, in some cases, the more prevalent or well known. To go through all childhood psychological disorders that are diagnosed in the DSM would go beyond the purview of this course. However, if you are interested in learning about this more extensive list, it is covered by most developmental and child psychology courses. So let's get started. So, intellectual developmental disorder, also known as intellectual disability. At the core of an intellectual disability is a deficit in cognitive or intellectual functioning. Historically, we labeled individuals with this presentation of deficits as having mental retardation, but this term was changed to intellectual disability with the passage of Public Law 111-256, also called Rosa's Law, to combat stigmatization and the misuse of the term into a derogatory term. While the terms intellectual disability and intellectual developmental disorder are considered interchangeable, we will use intellectual developmental disorder in this course. While considering intellectual developmental disorder, there are two primary areas of major deficits: intellectual functioning, which is criteria A, and adaptive functioning, which is criteria B. So, Um, intellectual or cognitive functioning refers to our ability to problem solve, to understand and analyze complex material, and to think abstractly, absorb information from our environment, learn from experience, plan, judge, and reason. Critical components include working memory, verbal comprehension, quantitative reasoning, cognitive efficacy, and perceptual reasoning. An individual with an intellectual developmental disorder has a significant deficit in this area as confirmed by clinical assessments and individualized, standardized, and culturally appropriate intelligence testing. The DSM-5 TR states that those with intellectual developmental disorder have scores approximately 2 standard deviations or more below the population mean. If a test has a standard deviation of 15 and a mean of 100, their scores will fall in the 65 to 75 range. Now, there's also criteria B. Adaptive skills are those that help us successfully navigate our daily lives. Our ability to understand safety signs in our environment, to make appointments, to interact with others, to complete hygiene routines, etc., are examples of adaptive functioning. These are the skills one needs to live independently and be socially responsible. Individuals with intellectual developmental disorder typically have adaptive skills that are far below what's expected given their chronological age. According to the DSM-5 TR, adaptive functioning involves adaptive reasoning in 3 main domains: conceptual, social, and practical. First, the conceptual domain, called the academic domain, involves competence in memory, language, math reasoning, problem solving, etc. Second, the social domain involves being aware of the thoughts and feelings of other people, showing empathy, interpersonal communication skills, and social judgment, for example. Finally, the practical domain involves learning and self management across life settings such as job responsibilities, personal care, and recreation. Now, for criteria C, it should be noted that this third criteria needs to be met. The onset of deficits described in criteria A and B must be present in the neurodevelopmental period. As such, it is most frequently diagnosed in children. Intellectual developmental disorder is not something that one would acquire in adulthood, even if an individual is diagnosed later in life in adulthood. If an individual experiences cognitive and adaptive functional decline in later years, but they didn't have any kind of issue with functioning earlier on, this is not considered an intellectual developmental disorder, but is more likely a neurocognitive disorder that may be due to a number of things, such as a traumatic brain injury or dementia, as we previously discussed earlier in the lecture. As such, although an individual can go undiagnosed until adulthood, and then as an adult be diagnosed with intellectual developmental disorder, there must be significant and undoubtable evidence of cognitive delay and adaptive functioning delay in the early developmental period. Otherwise, an adult would not be diagnosed with intellectual developmental disorder. So, the other piece is rather than IQ scores, intellectual developmental disorder is assigned a severity specifier based on the level of delays related to adaptive functioning. Severity ranges from mild, least severe, to moderate, to severe, to profound, which is the most severe. Severity is considered in relation to three domains of conceptual, social, and practical. For instance, a specifier of severe would result in the child having little understanding of written language or concepts involving numbers, quantity, and money, the conceptual domain. Speech and communication being focused on the here and now within everyday events would be the social domain. And not being able to make responsible decisions regarding the well being of self or others necessitating supervision at all times would be the practical domain. Now, individuals with intellectual developmental disorder have difficulties with social judgment, assessing risks, emotions. They tend to be gullible and lack awareness. This can lead to increased rates of accidental injury, being exploited by others, possible victimization or physical and sexual abuse, and unintentional criminal involvement. They may also become distressed about their intellectual limitations. Now, the DSM-5 TR uses the term intellectual developmental disorder to clarify its relationship with the ICD-11 classification system, which uses the term disorders of intellectual development. The equivalent term of intellectual disability is placed in parentheses for continued use, and it should be noted that both terms, intellectual developmental disorder and intellectual disability, are used in medical research literature. And while the term intellectual disability is more commonly used by educators, advocacy groups, and the lay public. Now, intellectual developmental disorder occurs in approximately 1% of the overall general population. And while the global prevalence varies by country and level of development. Now, prevalence is 16 per 1,000 in middle income countries, but 9 per 1,000 in high income countries. Intellectual development disorder is more common in males than females, although sex ratios are inconsistent in the literature. It's hypothesized that the reason there is a higher occurrence of intellectual developmental disorder in males is due to general genetic vulnerability, often linked to the X chromosome and issues on it that males experience. Prevalence is higher in youth than in adults, and there's no significant differences between ethno-racial groups. From a comorbidity perspective, intellectual development disorder is often comorbid with other medical and physical conditions, as well as other neurodevelopmental conditions, including autism and ADHD. Moreover, depression, bipolar, and anxiety disorders are often comorbid with intellectual developmental disorder. Impulse control disorders, major neurocognitive disorder, and stereotypic movement disorders are frequently comorbid. Now, the onset of intellectual development disorder is in the developmental period, though etiology and severity of brain dysfunction affect exact age and characteristic features at onset. For individuals with more severe intellectual development disorder, delayed motor, language, and social milestones are typical within the first 2 years of life. For individuals with mild intellectual development disorder, impairments may not be identifiable until school age when problems with academic learning are evident. Now, a specific learning disorder is something else. It's something different, but it's within this same broader category of the disorders that tend to occur in childhood, or at least be identified in childhood. It's characterized by persistent difficulties learning critical academic skills during the years of formal schooling, such as reading of single words accurately and fluently, or arithmetic calculation, performance of the affected academic skills being well below expected for age, and learning difficulties being apparent in early school years for most individuals, and that the learning difficulties are considered specific for four reasons. First, the learning difficulties are not better explained by intellectual developmental disorder, global developmental delay, hearing or vision disorders, or neurological or motor disorders. Second, they cannot be attributed to more general external factors such as economic or environmental disadvantage. Third, they cannot be attributed to neurological disorders such as pediatric stroke, motor disorders, or vision or hearing disorders. Fourth, a learning difficulty can be restricted to one academic skill or domain. Now, historically, learning disorders were diagnosed when there was a significant discrepancy between an individual's intellectual and cognitive ability as measured by an intelligence test and their academic achievement as measured by a standardized achievement test, as this was required by the DSM-4 TR criteria. This method is referred to as the discrepancy model. Now, many still use this model, and nothing in the DSM-5 TR disallows it. But the DSM-5 criteria were rewritten to allow more flexibility. Ultimately, a discrepancy between one's IQ and academic achievement is no longer required. However, there must be specific data indicating an individual is performing significantly below what would be expected given their chronological age. In addition to significant academic deficits, there must be evidence that efforts like tutoring or increased and specialized instruction were utilized to improve abilities within a specific area before diagnosing a specific learning disorder. This is to ensure that an individual has had full access to educational material and supports before a professional assigns a learning disorder diagnosis to them. And in school systems, this is where tiered interventions have come into play. So once an individual has been diagnosed with a learning disorder, all academic domains and subskills that have been impaired should be noted as follows. With impairment in reading, the individual has trouble comprehending material, reading fluently and quickly, or reading words accurately. With impairment in mathematics, the individual has trouble with number sense, memorization of arithmetic facts, math reasoning, and calculation. With impairment in written expression, the individual has trouble with accurately spelling words, using correct punctuation and grammar, or with writing and clearly clearly organized. And there's also matters of dyslexia and dyscalculia. Now, technically, dyslexia and dyscalculia are not diagnoses in the DSM-5 TR, but they are alternative terms used to describe learning disorders in reading, which would be dyslexia, and learning disorders in math, which would be dyscalculia. Dyslexia refers to a pattern of learning difficulties characterized by problems with accurate or fluent word recognition, such as decoding, I should say, and spelling. Dyscalculia refers to a pattern of learning difficulties characterized by problems processing numerical information, learning arithmetic facts, and performing accurate or fluent calculations. That's a quote from the DSM. Although these two terms are used very frequently in school systems and by professionals such as speech and language pathologists, they're not diagnoses and are considered alternative terms in the DSM-5 TR. Instead, a mental health professional will diagnose a specific learning disorder with impairment in reading for dyslexia and a specific learning disorder with impairment in math for dyscalculia. This is an excellent example of how professionals will sometimes discuss the same phenomena but use totally different terminology. Now, although intellectual developmental disorder and specific learning disorder may seem very similar, it's important to not confuse the two as they are very different. When thinking about both disorders, we have three distinct core areas to consider: adaptive functioning, cognitive intellectual ability, which is represented by IQ, and academic achievement. Um, a rudimentary uh, way to think about this is with intellectual developmental disorder, we're concerned with adaptive functioning and IQ. And with specific learning disorder, we're concerned with IQ, sort of, and academic achievement. Although IQ matters, again, sort of, in both disorders, the reason it's important varies slightly. Because IQ is considered in both disorders, people often intertwine and confuse the two. Let's take a minute to think about this. IQ is what we are cognitively able to do, what we can do. Adaptive skills and academic achievement refers to what we are doing. In intellectual developmental disorder, if we cannot perform in the average range on an IQ test and we are not performing daily living tasks appropriately for our chronological age, we would not expect a 7-year-old to make their own doctor's appointment, for example, but would expect them to know to dial 911 in an emergency. This is indicative of intellectual developmental disorder or intellectual disability. Now, to differentiate between a specific learning disorder and an intellectual developmental disorder, it is useful to consider the discrepancy between what is expected of an individual, what they can do, and what they are doing. If an individual cannot perform averagely because their IQ is substantially below average, we would not expect them to perform at an average level on academic tests. We would not, so, uh, for example, if a person's IQ is 70 and they cannot function typically on cognitive tasks, we would not expect them to achieve an academic score of 100, a 30-point jump from what they can do to what they're doing. If an individual has an IQ of 70, we would expect their academic score to be around 70, which would not necessarily indicate a specific learning disorder, even though the score is low. In this case, they would be performing as expected, so the low score, achievement score, would reflect low cognitive abilities resulting from intellectual development disorder. However, if there is a large discrepancy between what a person can do and what they are doing, for example, somebody with an IQ of 100 scoring a 70 on an academic achievement test, this could indicate a specific learning disorder because they're underperforming relative to what they can do. So, what about epidemiology and comorbidity? Well, specific learning disorder occurs in approximately 5 to 15% of school age children in Brazil, Northern Ireland, and the United States. It's more common in males than females, and suicidal thoughts and behaviors were found in U.S. adolescents aged 15 years in public school presenting with poor reading ability. So there's some comorbidity there. Um, the the different types of specific learning disorder are comorbid with one another. So impairment in math with reading, or other neuro developmental disorders like ADHD, autism spectrum disorder, developmental coordination disorder, and communication disorders, anxiety disorders, and behavioral problems and depressive disorders are all comorbid with each other. There can be a number of reasons for this. But the other piece is onset, recognition, and diagnosis of specific learning disorder typically occur during the elementary school years, as this is when children are required to read, spell, write, and learn math. Now, during early childhood and before the child starts school, there may be warning signs to include delays or deficits in language, problems with rhyming or counting, and issues related to fine motor skills and need for writing. Specific learning disorder is lifelong. though an individual may experience persistent shifting array of learning difficulties across the lifespan. According to the APA and the DSM, negative functional consequences occur across the lifespan and can include, quote, lower academic attainment, higher rates of high school dropout, lower rates of post secondary education, higher levels of psychological distress, and poorer overall mental health with higher rates of unemployment, underemployment, and lower incomes. Now, individuals with extreme cognitive functioning abilities are often overlooked. For example, children that are gifted but have a reading disorder often go undiagnosed because their deficits look like average abilities to others. Here's an example to illustrate this. A second grader with a high cognitive ability earns all A's. She excels in math and writing. In fact, she's far past her peers in this area, or these areas, I should say. She has long learned her multiplication and division facts and is even working on some basic geometry skills. She can write and has been drafting paragraphs with ease and has even started to learn to write essays. She loves math and writing, but she dislikes reading. When in class, she reads just like her peers. No more advanced, but right on second grade level expectations. She finds reading to be more difficult, though, and it doesn't come nearly as easily as math and writing. However, because she's on track compared to her peers, her teachers and parents don't recognize any issues. Her grades are fine, and her school standardized testing is not a problem. What if you learned that her standardized math and writing scores matched her intellectual ability, meaning her can do and her doing is matched, but her reading score is doing, although average, is well below what would be expected given her IQ, her can do, and is much lower than her math and writing scores despite still being an acceptable score? Would you say she may have a reading disorder? If you said yes, you're right, actually. If you said no, well, quite frankly, you might be right too. The fact is, this is a gray area. Previous versions of the DSM would have made it easy to diagnose this child with a learning disorder in reading. The DSM 5 TR makes it a bit tougher. If this is a reading deficit compared to her own abilities caused by an apparent impairment in an internal stress preventing her from advancing in math and writing because her reading abilities were lagging behind her other abilities, one would be inclined to diagnose her with a specific learning disorder in reading. However, one can see how this child could be overlooked and undiagnosed for years, which is how some of these things tend to occur and then be diagnosed later in life, like in college when you're having an issue in one area but not another. Now, let's reverse the scenario. A second grade girl has a diagnosis of intellectual developmental disorder, intellectual disability. She struggles in all areas of academics. However, her math abilities are even more behind her reading and writing. Do you think one could make a case for specific learning disorder in math? Well, theoretically, they could, but it takes a lot of careful documentation of intervention attempts and standardized testing that makes it undoubtedly clear that this is true, similar to the previously mentioned example. And when an individual has an IQ that lands in an extreme low or high, their weaknesses are often missed. So, as such, providers and educators really need to be careful not to overlook potential specific learning disorders in these individuals. So, what about autism spectrum disorder? Everybody's talking about this these days. And one of the big reasons why it's being talked about is the rate of diagnosis. Are the rates going up? Are they not? Are we just detecting something that's always been present more because we're getting better at it? Is there more discussion about mental health issues and learning differences and perceptual differences and all of the above? Um, Maybe yes, maybe no. The jury's still out on this, but there's more to discuss in these areas. But the essential let's take a step back and let's look at what the essential features of ASD are, because this what's referred to as neurodivergence is certainly in the spotlight these days. So, the essential feature of autism spectrum disorder, or ASD as it's referred to, are twofold and include persistent impairment in reciprocal social communication and social interaction, which is criteria A, and restricted repetitive patterns of behavior, interest, or activities, which is criteria B. It's described as a spectrum because the varying manifestations of the disorder, due to the severity of the autistic condition, developmental level, chronological age, or chronological level, I should say, and gender. So, criteria A, social communication and social interaction. The child must present with all of the following symptoms. These include behaviors such as poor eye contact, dominating a conversation, or lacking ability to maintain conversation due to absent or limited reciprocity, so such as the to and fro of a conversation and the exchange of information, trouble with integrating verbal communication with nonverbal communication. For example, using gestures, body language, or visual guiding is challenging, or understanding it, and struggles with maintaining friendships or relationships in general. And individuals with these difficulties have troubles understanding others' perspectives, reading emotions, and inferring minor and subtle social cues. Then there's criteria B, restricted and repetitive behaviors, interests, or activities. The individual must present with at least two of the following. First, they engage in stereotype movements, frequently called stereotypy, such as hand flapping, spinning, or any repetitive movement that does not have an obvious function. They might display restricted or repetitive play, such as lining up toys or fixation on a part of a toy or a button. Individuals may have excessive and restricted interests, such as being overly interested in history, dinosaurs, or robotics. This is sometimes referred to as a special interest. Their interest may be so intense that if discussing their interest, it's difficult to get them to move on to a new topic, or it might be the only thing about which they will engage in a conversation. Now, there's also restricted behaviors that might include strict adherence to routines and schedules. So they may become very dysregulated if there's a new routine or that's introduced, or their routine is changed in any way. Moreover, sensory concerns may be of particular relevance. Some individuals may seek out stimulation, so sensory seeking behavior is often referred to as stimming, as a self-soothing method. In fact, many repetitive movements can be seen as sensory stimulating. Examples, although not an exhaustive list, of stimming may include rubbing hands on a rough material repetitively, which is a tactile stim, putting objects on their mouth or lips, which is an oral stim, grunting, or making non-functional vocalizations, which is a vocal stim, or looking at lights or visual lines in odd ways, which is a visual stim. Others may avoid certain sensory input, which is known as sensory aversion. For example, being very averse to certain textures or heightened sensitivity to pitch or volume of noise or bright lights. So, individuals, in order to be diagnosed with ASD, must exhibit both social communication concerns and restricted repetitive behaviors, interests, and activities to be diagnosed. Furthermore, these symptoms must have been present very early in development. Although language delays are common in children with ASD, they're not necessarily required. Moreover, there's often a misconception that if a child has severe ASD, they're nonverbal, meaning they do not have language. This is not accurate. Children with ASD present very differently from each other. Regarding ASD, Dr. Stephen Shore said, quote, "If you've met one person with autism, you've met one person with autism." In other words, one child with ASD may have symptoms that present very differently from another child with ASD, but both children have ASD. Dr. Morgan Ida also theorized that autism may be a series of interrelated disorders that are conceptualized on a spectrum but are in some ways distinct. ASD is diagnosed within the context of language development and intellectual development, given that these factors may indicate prognosis. As such, clinicians will assign specifiers that identify if there is any evidence of language impairment or intellectual impairment. For intellectual impairment, separate estimates of verbal and nonverbal skill are necessary. For language impairment, the clinician should consider repetitive and expressive language skills separately, since receptive may lag behind expressive language development in ASD. Moreover, ASD is diagnosed in the context of current severity for both social communication impairments and restricted, repetitive patterns of behavior, interests, or activities. The clinician will assign a severity level to each of the two main criteria, indicating how much support the individual needs. Level 3 indicates, quote, requiring very substantial support. Level 2 means requiring substantial support, and level 1 states requiring support. Now, intellectual and or language impairment is common in many individuals with ASD. They may have difficulty seeing the world from another person's perspective, called theory of mind deficit. They may have motor deficits that are also present and can include an odd gait or being clumsy and walking on their tiptoes. They may engage in self injury, such as banging their head or biting one's wrist. Um, Now, the behavioral features of ASD first become noticeable in early childhood, as someone will present with a lack of interest in social interaction during their first years of life. For children in which skills have been lost, parents and other caregivers may provide a history of gradual or relatively rapid deterioration in social behaviors or language skills occurring between 12 and 24 months. In terms of symptoms, the first symptoms of ASD typically involve delayed language development, often accompanied by a lack of social interest or unusual social interactions. Odd play patterns, such as carrying a toy around but never playing with it, and unusual communication patterns, such as knowing the alphabet but not responding when their name is said. During the second year, odd and repetitive behaviors and the absence of typical play become more apparent. Now, what about the etiology and comorbidity? Well, ASD has been reported in 1 to 2% of the US population. Prevalence is lower among African American populations and Latinx populations, at 1.1% among African Americans and 0.8% among Latinx populations, when compared to Caucasian children, where it's about 1.3%. In non US countries, prevalence has approached 1% of the population, and the male to female ratio globally is 3 to 1. Individuals with ASD are at greater risk for suicide and death, and children with ASD who had impaired social communication had a higher risk for self-harm with suicidal intent. Also, higher risk for suicidal thoughts and suicide plans by age 16 compared to those without impaired social communication, which suggests that it is a feeling of being socially ostracized or socially different or in an out group that may contribute to these rates. Now, comorbid disorders are very common for children with autism. Specifically, 70% of children with autism have a comorbid diagnosis. Furthermore, 40% of children with autism have two or more additional disorders, and ASD is comorbid with intellectual developmental disorder, not in all cases, of course, but it can be, and a language disorder, such as and specific learning difficulties, anxiety disorders, depression, ADHD, and avoidant restrictive food intake disorder. So we mentioned ADHD, and ADHD is conceptualized as a neurodivergence, as is autism spectrum disorder. There is some comorbidity here, but what is ADHD? This is something that is discussed quite a bit, because there's a lot of people who self-identify as having it. But ADHD, or attention deficit hyperactivity disorder, is a disorder in which individuals have difficulty with executive functioning, and individuals' decision-making ability, which involves working memory, inhibition of inappropriate or unhelpful responses, and the inability to focus on relevant information while dismissing unimportant or irrelevant information. Essentially, an individual's ability to regulate cognitions, emotions, and behaviors are impaired. Individuals may lose things frequently, talk excessively, forget assignments, appointments, fidget frequently, move constantly, get distracted, and struggle with organization. Symptoms also are required to be present in more than one setting. For example, if symptoms are only present in school, an individual would not be diagnosed with ADHD. Symptoms are generally organized into two main categories: hyperactivity and impulsivity symptoms and inattention symptoms. An individual receives a diagnosis of ADHD with the needed specifier if there are one, at least six symptoms of inattention for this specifier, two, at least six symptoms of hyperactivity and impulsivity for this specifier, or three, six symptoms or six of each of the preceding two combined for the combined specifier. The exact symptoms that an individual may experience would be, children who are attentive tend to lose things, for example. They tend to lose things necessary for tasks or activities. They do not listen when spoken to directly. They do not follow through on instructions and fail to finish tasks. They do not give close attention to details or make careless mistakes and are easily distracted by extraneous stimuli. They are also forgetful in daily activities. They avoid things that they dislike or are reluctant to participate or partake in activities requiring sustained mental effort. They fail to sustain attention in tasks or play activities and have problems organizing tasks and activities. So, of these nine symptoms, six or more must be displayed to receive the specifier of inattentive symptoms. And they should have all occurred within the last 6 months, whatever symptoms are displayed. There's also hyperactivity and impulsivity symptoms. So these symptoms are related to excessive energy and movement as well as impulsivity. Individuals with these symptoms are often described as high energy or on the go, talkative, and fidgety. These children may have a hard time waiting their turn, standing still, or remaining in their seat, or engaging in leisure activities quietly. They blurt out answers before the question has been completed and often interrupt or intrude on others. Of these nine symptoms, six or more, again, must be displayed to receive the specifier of hyperactivity and impulsivity symptoms, and should have occurred again in the last 6 months. The combined presentation, in order to receive that specifier, an individual must display at least six inattention symptoms and six hyperactivity symptoms and impulsivity symptoms for the past 6 months. And there's also associated features. So individuals with ADHD with any specifier display emotional dysregulation or emotional impulsivity, are often quick to anger, easily frustrated, and overreact emotionally. They may exhibit neurocognitive deficits and often show delays in language, motor, or social development. And when we talk about the development in course, excessive motor activity is often observed by parents when a child is a toddler, but, quote, symptoms are difficult to distinguish from highly variable normative behavior before the age of 4 years. So in preschool, hyperactivity is most common, and ADHD is most often identified during the early elementary school years, I should say, and throughout elementary school years as the inattention becomes more prominent and impairing. Hyperactivity becomes less prominent during adolescence and is confined to being fidgety, restless, or impatient. In adulthood, impulsivity, inattention, and restlessness may remain problematic even if hyperactivity is diminished. So, what about prevalence and comorbidity? Well, ADHD occurs in about 7.2% of children worldwide, with cross national prevalence rates ranging from 0.1% to 10.2% of children and adolescents, and higher prevalence rates occurring in special populations such as foster children and correctional settings. ADHD is more often diagnosed in males than females, and females are more likely to present primarily with inattentive features. Because predominantly inattentive symptoms are not as disruptive and noticeable as hyperactivity or impulsivity symptoms, predominantly inattentive presentations of ADHD may go undiagnosed or be diagnosed much later than ADHD, predominantly with hyperactive and impulsive or combined presentations. Finally, ADHD is a risk factor for suicidal ideation and behavior in children. As far as comorbidity is concerned, according to the CDC, approximately 60% of children with ADHD have another comorbid disorder. About 50% of children with ADHD combined presentation, and about 25% of children with ADHD, predominantly inattentive presentation, are also diagnosed with oppositional defiant disorder. Conduct disorder is also highly comorbid with ADHD. About 25% of youth with ADHD and combined presentations, and most children and adolescents with disruptive mood dysregulation disorder have symptoms that also meet the criteria for ADHD. Learning disorders are also commonly comorbid with ADHD. However, differentiating if a learning disorder is present in addition to ADHD requires a thorough evaluation. And mood and anxiety disorders, as well as OCD and intermittent explosive disorder, are less likely to be comorbid than other behavioral disorders. However, they do occur at a high rate in children with ADHD compared to children without ADHD. Many individuals with ADHD report daytime sleepiness that could meet the criteria for hyposomnolence disorder. There's also tic disorders, moving on from ADHD. Now, tic disorders consist of three separate diagnoses. The most commonly known of the three is Tourette's disorder. The second diagnosis is persistent chronic motor or vocal tic disorder, and the third is provisional tic disorder. We'll start by discussing tic disorders generally and then move on to the specifics of each of them. Now, general symptoms. These disorders tend to present before adulthood, so usually before 18 years of age. Typically speaking, the time in which they present is between the ages of 4 and 6 and are most severe in symptomatology between the ages of 10 and 12. For all three disorders, tics are present. Now, the DSM defines a tic as a, quote, sudden, rapid, reoccurrent, non-rhythmic motor movement or vocalization, unquote. Tics can be either motor movements or vocalizations, and these can be simply meaning that they only involve one movement or vocalization, or they can be complex, meaning that they involve multiple movements, vocalizations, or a combination of movements and vocalizations with the same tic. Tics are largely considered to be involuntary, and it's common for tics to increase in severity for a period of time and then resolve or drastically reduce for a period of time. Now, Tourette's disorder occurs when both motor and vocal tics are present. More than one motor tic must be present, and at least one vocal tic must occur. To be classified as Tourette's disorder, that needs to be the case. And the tics do not have to occur together and do not have to be complex tics. Though tics may increase and decrease in frequency, they will have persisted for more than 1 year since the first tic onset. But for persistent chronic motor or vocal tic disorder, this is when either one or more of the motor tic or one or more of the vocal tic is present. However, vocal and motor tics are not both present. These again can be simple or complex, and only the presence of one tic is required. To receive this diagnosis, the individual must have never been diagnosed with Tourette's disorder. And the mental health professional will specify whether the disorder presents with the motor tics or with vocal tics only. And though tics may increase and decrease in frequency, they will have persisted for more than 1 year since the first tic onset. Then finally, with this, there is provisional tic disorder. And this diagnosis is used if there are single or multiple motor and vocal tics, but they've been present for less than 1 year since the first tic onset. The criteria for Tourette's disorder or persistent chronic motor or vocal tic disorder will never have been met for this disorder. So what about the prevalence? Well, tic disorders are relatively rare. The CDC estimates that approximately 0.3% of children are diagnosed with Tourette's disorder, while the DSM reports that an estimated 3 per 1,000 for the prevalence of clinically identified cases. Tic disorders are more common in males, and there are lower rates in African American and Latinx individuals. Comorbid disorders are common, with 86% of individuals with Tourette's disorder also having another psychological disorder. ADHD, disruptive behavior, and OCD are commonly comorbid with tic disorders, with about two-thirds of individuals with Tourette's disorder also having ADHD and one-third having OCD. In terms of differential diagnosis, tic disorders must be distinguished from OCD and related disorders. The compulsions of OCD attempt to prevent or reduce anxiety or distress and are usually performed in response to an obsession, while individuals with a tic disorder feel the need to perform the action in a particular fashion equally on both sides of the body or a specific number of times or until a just right feeling is achieved. As for bodily focused repetitive behavior disorders, they tend to be more goal directed and complex than tics. So finally, we've gone over a whole host of common and to an extent uncommon disorders. Let's wind up the course by talking about legal issues related to mental illness because these are significant. So when individuals with mental illness behave in erratic or potentially dangerous ways to either themselves or others, then something must be done. The responsibility to act falls on the government through what is called father of the country or country as parent action. In this case, action involves involuntary commitment in a hospital or mental health facility, and it's done to protect an individual and express concern over their well-being, much like a parent would do for a child. An individual can voluntarily admit themselves to a mental health facility, and upon doing so, staff will determine whether their treatment and extended stay are needed. It can also be done by a psychotherapist, and in fact, a psychotherapist has a duty to do so if the person gives enough information to suggest that they are a imminent threat to themselves or others. And we'll talk more about that in a bit. So when we talk about the criteria for civil commitment, though states vary in criteria used to establish the need for civil commitment, some requirements are common across states. First, the individual must present a clear danger to either themselves or others. Second, the individual demonstrates that they are unable to care for themselves or make decisions about whether treatment or hospitalization is necessary. Finally, the individual believes that they are about to lose control and so needs treatment or care in a mental health facility. There's also the assessment of dangerousness. Dangerousness can be defined as the person's capacity or likelihood of harming themselves or others. The process for civil commitment does vary state to state, but some procedures are held in common. First, a family member, mental health professional, or primary care practitioner may request that the court order an examination of the individual. If the judge agrees, two professionals, such as a mental health professional or a physician, are appointed to examine the person in terms of their ability for self-care, need for treatment, psychological condition, and likelihood to inflict harm on themselves or others. Next, a formal hearing gives the examiners a chance to testify as to what they found. Testimonials may be also provided by family and friends or by the individual themselves. Once testimonies conclude, the judge renders judgment about whether confinement is necessary and if so, for how long. Typical confinement that isn't an emergency 72-hour hold or 48-hour hold or 72-hour hold or 48-hour hold typically lasts from 6 months to 1 year, but an indefinite period can be specified too. If in the latter case, the individual has periodic reviews and assessments. And in emergencies, this process stated above can be skipped and short-term commitment can be made, especially if the person is an imminent threat to themselves or others. This is often referred to as a 5150 hold. Before we move on, consider for a minute that a person who is accused of a crime is innocent until proven guilty. Has a trial, and if found guilty beyond a reasonable doubt, or almost complete certainty, is only then incarcerated. This is not true for the mentally ill, who may be committed to a facility without ever having committed a crime or having trial, but simply because they were judged as having the potential to do so or was seen as dangerous. This potential means that there must be a quote unquote clear and convincing proof, which the US Supreme Court defines as 75% certainty. The standard to commit is much different for those accused of criminal acts and those who are mentally ill. Now, as you might have learned in your introductory psychology course, confidentiality guarantees that information about you is not disseminated without your consent. This applies to students participating in research studies as well as patients seeing therapists. When we talk about privileged communication, confidentiality is an ethical principle, while privileged communication is a legal one, and states that confidential communications cannot be disseminated without a patient's permission. There are a few exceptions to this, which include the client being younger than 16, when they are a dependent elderly person, and a victim of a crime, or when the patient is a danger to him or herself or themselves, to name a few. And within that framework, we have the duty to warn, which is the 1976 Tarasoff case versus the Board of Regents of the University of California ruling, in which the California Supreme Court said that a patient's right to confidentiality ends when there is a danger to the public, and that if a therapist determines that such a danger exists, they are obligated to warn the potential victim. Tatiana Tarasoff, a student at the University of California, was stabbed to death by a graduate student in 1969 when she rejected his romantic overtures. And despite warnings by the assailant's therapist that he was an imminent threat, the case highlights the fact that therapists have a legal and ethical obligation to their clients, but at the same time, a legal obligation to society. So, how exactly should they balance these competing obligations, especially when they're vague? In the 1980 case of Thompson versus the County of Alameda, they ruled that a therapist does not have a duty to warn if the threat is nonspecific. So, when we think about these issues, a therapist has a tremendous responsibility to balance. Privileged communication, confidentiality is sacrosanct, but there is a broader responsibility as an agent of the public good. So, if the threat is specific, and if the person is a clear and present danger to another person or a clear and present danger to themselves, there either has to be a warning given to the person who is being threatened, or the potential needs to be considered for involuntary commitment, at least for a brief period of time. So that rounds out the course. It has been a pleasure and an honor to share all of this information with all of you. I hope you have found this experience to be as rewarding as I have found it to share all of it. If you have any questions, feel free to email me or message me. Otherwise, I leave you to the remaining assignments for the course, including any discussions or papers or exams. Take good care and be well.